My name is Andreas Engert. I'm chairman of the German Hodgkin Study Group and I work in Cologne, Germany. Today I want to discuss with you a case of early stage Hodgkin lymphoma. So the staging of these patients is rather equal between major groups worldwide. Our group defines early stages as patients in stages 1 and 2, A or B, without large mediastinal mass or extranodal disease. All the other stages 3 and 4 and 2B with extranodal disease or large mediastinal mass are classified as advanced stages. Today we want to focus on these early stage patients, and I have a young 33-year-old lady who was diagnosed with classical Hodgkin lymphoma, nodular sclerosis. Mediastinal lymph nodes were mainly involved. She didn't have any symptoms, any B symptoms, any night sweats or fever or weight loss. So she was classified as stage 2A. And the question to you would be, what do you do with a stage 2A patient? There are a couple of possibilities based on our HD10 study for patients with early favorable Hodgkin lymphoma. We would treat this patient with 2 cycles of ABVD followed by 20 gray involved field radiation. The HD10 study really demonstrated that this treatment is as effective as 4 cycles of ABVD followed by 30 gray radiotherapy. So this would be the treatment we recommend, 20 gray of radiation given after 2 cycles of ABVD. However, you also know that there is a clear attempt and need to reduce toxicity also in early favorable patients, and that was successfully done with HD10 as just described. But now the questions are, can we reduce this further? Can we do just with chemotherapy alone, no radiation at all? And there are 2 studies that address this issue. The EOTC French H10 study and the British Rapid study. Both studies came to a similar conclusion, that it is feasible, it can be done. However, the final decision, the final answer to this question is not available yet, because the EOTC stopped that trial early and the number of patients are really rather low. There were not that many events. However, in both these studies there were similar number of events in the arm that did not have additional radiotherapy. So from that one has to be rather careful at this stage, and the British study, the Rapid study, was a negative study in that sense. So at this stage we would say that still 2 cycles of ABVD followed by 20 gray is the standard of care. Our patient, however, just had 4 cycles of ABVD. She responded well. She achieved a complete remission. However, she relapsed about 2 years later. And at relapse, she had a more advanced disease, as shown on these slides, with again mediastinal lymph nodes, but also importantly pulmonary infiltrates proven to be Hodgkin's, and she also on top of that had bone marrow involvement. So she was really in advanced stages and required treatment for relapse. What is important at this stage is that you verify that the patient indeed has Hodgkin's, because if you have a lymph node involvement and you might have done a PET at this stage and the PET shows you multiple areas of activity, it could still be something else. It must not be Hodgkin, although the likelihood is rather high. It could be something like sarcoidosis, infectious disease, tuberculosis. That's why we, before we put a patient into high-dose chemotherapy, always request a biopsy that proves that this is relapsed Hodgkin's disease. The treatment for a relapsed Hodgkin patient in this setting would typically be 2 cycles of chemotherapy followed by high-dose chemotherapy. We usually use DHAP, non-cross-resistant chemotherapy. Others use ICE or IGF. There is no really best treatment to be selected here. The major factor is that this treatment is given in a timely fashion, and this is followed by beam and autologous stem cell transplant. And so that's what we did in this patient, and she has a chance of being cured long-term of more than 50%. This can be estimated with risk factors, and here one of the most relevant risk factors is the time to relapse, and she had more than 2 years, so that puts her in a rather good risk group. If patients relapse within 1 year, then the prognosis is much worse, and that's not what she has. She has sort of late relapse, very late relapse, 2 years. So her chances still are pretty good for long-term cure. However, this is something we see in patients who did not receive additional radiotherapy, because additional radiotherapy can nicely control residual disease, larger tumor masses being present after chemotherapy.